Good afternoon, and welcome to our fourth session in our first virtual Successful Aging Expo. Today's session is entitled Dementia and Memory Care. My name is Al Manzi. I'm the president and CEO for Prairie Mountain Media and publisher for the Longmont Times Call. Before we start today, I'd like to remind everybody to please visit the Expo and recognize our sponsors. You can do that through the Times Call website. At the end of today's presentation, there'll be a 15-minute or so question and answer period. And I also remind everybody that you can ask questions during the presentation by simply typing them in either the chat feature or in the Q&A feature, which is in the little boxes at the bottom of your device. So please feel free to ask questions at any time. At the end of the presentation, I will take those questions first from the audience and then add any in that come in during the question and answer period. Today's presenter will be Jeanette Allen. She's Vice President of Health and Wellness with Balfour Senior Living. So please join me in welcoming Jeanette Allen.
Hey, everybody. Good afternoon, everyone. I'm Jeanette Allen. I work for Balfour Senior Living as the Vice President of Health and Wellness. I have been working in senior living and working with older seniors most of my career, over 25 years now, and really love my role here at Balfour. So our objectives today are to cover some FAQs on dementia and mild cognitive impairment, talk about the major types of dementia. There are hundreds of types of dementia, but we'll go over the main types, some early signs of dementia, stages of dementia and early recognition, the brain changes with dementia, what it's like to live with dementia, and then demystifying and destigmatizing dementia, and resources and engagement. Mild cognitive impairment, or MCI, causes cognitive changes that are serious enough to be noticed to the person who's affected, their family and friends, but it doesn't interfere with the ability to complete everyday tasks. Approximately 15 to 20% of people age 65 or older do have mild cognitive impairment. People who are living with MCI are more likely to develop Alzheimer's disease or other dementias than people without MCI. It's important that people experiencing cognitive changes seek help as soon as possible for a diagnosis and possible treatment. Occasionally, not very often, but MCI can be reversed if the cause of the cognitive impairment is attributed to a medication change or a medical issue such as an infection. The causes of MCI are not yet completely understood. Experts believe that many cases, but not all, result from brain changes that occur in the very early stages of Alzheimer's disease or other dementias. Risk factors most strongly linked to MCI are the same as those for dementia: advancing age, a family history of Alzheimer's or another dementia, and conditions that raise risk for dementias like cardiovascular disease. When diagnosed with MCI, what should you do? Lifestyle changes. A focus on overall brain health to reduce cognitive decline may include increasing exercise, stopping smoking, which is a huge risk to your cardiovascular system, focus on improving your cardiovascular health, and eating a diet low in fat and high with vegetables and fruits, and getting adequate sleep. Recommended cognitive and mental health interventions include strategies to enhance cognitive function. And sometimes those cognitive functions can be enhanced by talking with a speech-language pathologist or a physical therapist. Cognitive training and stimulation, reality orientation, and reminiscence therapy may also be beneficial. Providers should help refer you to mental health experts for psychological and behavioral therapies, counseling, and peer support groups. Planning for a more safe and secure future. Being diagnosed with MCI Your provider should be guiding you and educating you on, and your caregivers on safety and financial planning, safety considerations, including reducing fall risk, what to do if you start to have wandering issues, and then driving implications. Giving up driving is something no one wants to consider or face, but it is something when you're diagnosed with MCI, it gives you the chance to think about it yourself and talk with your caregivers and your providers about when the right time is to give up that driving. Discussing appropriate living arrangements and ongoing care needs. Consider referral, as I mentioned already, to a physical therapist to improve function and protect against slips and falls, and or a speech language pathologist can help with cognitive strategies. It's extremely important. As a nurse who's worked in this field for a very long time, this is the time to have conversations about end of life choices. If you haven't already done that, if you haven't addressed making someone your durable power of attorney for healthcare and for finance, this is the time to have those conversations. Don't wait till it's too late where you can't make those decisions yourself. And in Colorado, and we have what is called a MOST form, M-O-S-T, which is a medical options and life-sustaining treatment. So if you get diagnosed with MCI, or even if you haven't been diagnosed and you're watching this presentation, if a doctor or a provider hasn't talked to you yet about a MOST form, that medical option and life-sustaining treatments is something you really want to have in place before you have a health crisis. Really, really important in the hospital setting and in the long-term care setting to have that MOST form all determined for you with your input. So Dementia Facts, I took a lot of this information right from the Alzheimer's Association website. Alzheimer's is the 6th leading cause of death in the United States. Currently, more than 5 million Americans are living with Alzheimer's disease, and that's not counting the folks that are already diagnosed with mild cognitive impairment. The number of people living with dementia worldwide is currently estimated at 50 million and will nearly triple by the year 2050. And I got that from the World Health Organization website, and that is data from September of 19. Just think about that, tripling numbers by 2050. So that's going to put a huge burden on our healthcare system and private citizens who are caring for people with dementia at home. 1 in 3 seniors dies with Alzheimer's or another type of dementia, and Alzheimer's and other dementias kill more than breast cancer and prostate cancer combined. Between the year 2000 and 2018, deaths from heart disease have decreased 7.8%, while deaths from Alzheimer's disease have increased 146%. That's a huge, huge increase. 16 million Americans are providing unpaid care for people living with Alzheimer's and other types of dementia. So those caregivers have that's a very high number of Americans who are caregivers, which is also a very difficult role to be in. Different types of dementia. I listed the top 4 or 5. Alzheimer's disease, also known as AD, accounts for 60 to 80% of dementias. Vascular dementia, which is, and I want to talk a little bit more about Alzheimer's. Alzheimer's disease is not a normal part of aging. The greatest known risk factor is increasing age, and we all know people are living longer with medical advances in the medical field. The majority of people with Alzheimer's are 65 and older, although there are about 200,000 Americans living with dementia under the age of 65, and we call that early onset dementia. Alzheimer's is a type of brain disease, just as coronary artery disease is a type of heart disease. It's also degenerative, meaning that it gets worse over time. Alzheimer's disease is believed to begin potentially 20 years or more before symptoms arise, with changes in the brain that are unnoticeable to the person affected. So only after years of brain changes do individuals experience noticeable symptoms, such as memory loss and language problems. Symptoms occur because nerve cells or neurons in parts of the brain that are involved in thinking, learning, and memory have been damaged and destroyed. Eventually, nerve cells and parts of the brain that enable a person to carry out basic bodily functions such as walking and swallowing are affected. People with dementia whose brains show evidence of cardiovascular disease are said to have vascular dementia. And vascular dementia accounts for approximately 5 to 10% of individuals with dementia. And it is more common with vascular dementia to see a mixed pathology or a mixed dementia because people are living longer. Those that are over 85 are showing really Alzheimer's disease and a vascular component. Most experts estimate that Lewy body dementia is the third most common cause of dementia after Alzheimer's disease and vascular dementia, accounting for 5 to 10% of cases. Frontal temporal lobe dementia, also known as Pick's disease, refers to a group of disorders caused by progressive nerve cell loss in the brain's frontal and temporal lobes, so the front of the brain and the temporal side of the brain. Accounting one main difference between frontal lobe dementia and Alzheimer's disease is that on average, frontal lobe dementia first presents itself significantly earlier in life. Symptoms usually appear between the ages of 45 and 65, while the majority of Alzheimer's cases occur in those over 65. Frontal temporal lobe dementia is responsible, the frontal lobes are responsible for helping inhibition and behavior regulation, so people with frontal lobe dementia will often exhibit strange or unusual behaviors and personality changes. Because personality changes associated with frontal lobe dementia are so pronounced, it is sometimes initially misdiagnosed as a mental illness. Diagnosis depends on the physician's knowledge, judgment, and observation of the patient. There is no definitive ability to diagnose frontal temporal lobe dementia. But those of us in the health field are really, we encourage when we get someone to us with a diagnosis of just general dementia, we really strongly encourage a visit to a neuropsychiatrist or a specialist, a neurological specialist in diagnosing and testing, because it really makes a difference in how we deal with someone with dementia. The treatments are different, the approaches are often very different, so it's really important that we understand a little bit more about what type of dementia that we are dealing with. Very often mixed dementia, and Kathy Miracle, who's our executive director at Cherrywood Village, will tell you very often, and she's got a master's in gerontology and is the Balfour resident expert on dementia. It is not me, it is Kathy. Kathy's got a ton of knowledge at Cherrywood Village, and Mary Scallon, who's our director of health and wellness at Balfour Longmont, is our expert in the Longmont area. But studies suggest that mixed dementia is more common than previously recognized, with more than 50% of people with dementia who were studied at the Alzheimer's disease centers having pathological evidence of more than one cause of dementia. In community-based studies, the percentage of mixed dementia cases is considerably higher. The likelihood of having mixed dementia increases with age and is highest in people ages 85 and older. Alzheimer's disease is best recognized and has the best chance of early intervention when we recognize it early. So noticing the early signs and symptoms for family members is really important. Memory loss that's affecting your daily life is one symptom, one early change. Challenges in planning or solving problems, difficulty completing familiar tasks, new confusion with time or place, trouble understanding visual images and spatial relationships, new problems with words in speaking and writing, misplacing things and losing the ability to retrace steps, decreased or poor judgment, which is a new onset for someone, withdrawal from work or social activities. This could indicate that someone is recognizing the changes in themselves, and in order to not have it be noticed, they withdraw from those social settings and work settings where those changes can be recognized, because at this stage of the disease, people are really fearful and afraid of other people noticing those changes. Changes in mood or personality. So if you're living with someone who you recognize these changes, or if you have a parent or a loved one, even a neighbor, someone you socialize with. It's okay to reach out to them one-on-one and say, listen, I'm noticing this and I'm worried about you, and ask them to get some early intervention with their physician. Stages of Alzheimer's dementia. This is really a simplistic, this is from the Alzheimer's Association. Early, middle, and later stages is very simplistic because we'll talk about later in our presentation a little bit about TPA-SNO's GEMS, which mirror the Allen Cognitive Scale of dementia. But to simplify it a little bit for the layperson, early stages, on average, a person with Alzheimer's, on average, lives 4 to 8 years after diagnosis, but can live as long as 20 years, depending on multiple other factors, the socioeconomical status and other health issues. Changes in the brain related to Alzheimer's, as we discussed earlier, it can happen years before any signs of the illness. Early stages of Alzheimer's, a person may function independently still and live very successfully in their home setting. They may still drive, work, and be part of social activities. Despite this, the person with the disease may feel as if he or she is having memory lapses, such as forgetting familiar words or the location of everyday objects. Symptoms may not be widely apparent at this stage, but family and close friends may notice changes, and a doctor would be able to identify symptoms using certain diagnostic tools. And I mentioned early, a neuropsychiatrist or a neurologist is the right specialist to see for early diagnosis. Middle stages of Alzheimer's, middle stages is typically the longest stage and can last for many years. As the disease progresses, the person with Alzheimer's will require a greater level of care, whether in the home or in a healthcare setting. The person may confuse words, get frustrated, angry, or anxious, act in unexpected ways, such as refusing to bathe or change clothes daily. Damage to nerve cells in the brain also make it difficult for the person to express their thoughts and perform routine tasks without assistance. In the middle stage, the person living with Alzheimer's can still participate in daily activities, but needs assistance. It's important to find out what the person can still do or find ways to simplify tasks to enhance independence with those tasks as long as possible. You don't want to start doing these things for someone. Very often that can increase agitation and feelings of poor self-worth. So it's important to maintain independence with assistance and find a way to do that. As the need for more intensive care increases, caregivers may consider adult daycare or a move to a memory care community. In the late stage of Alzheimer's, individuals will lose the ability to respond to their environment the way they were used to carry on a conversation, and eventually to control movement. They may still say words or phrases, but communicating becomes much more difficult. Person with Alzheimer's may not be able to initiate engagement as much as they were in earlier stages during the late stage, but he or she can still benefit from interaction in many ways, like listening to relaxing music or receiving reassurance through gentle touch. During this stage, caregivers may want to use support services. One of the support services that we use in the memory care community setting is using hospice services. Hospice services are always available to you in the home as well, and hospice can help provide comfort and dignity near the end of life. Hospice can be of really great benefit to people in the final stages of Alzheimer's and other dementias, and a really great support for families. I want to put in my plug here for hospice because we are very blessed to partner with some of the best hospice organizations in the country, not just in Colorado, but we partner with agencies who really they're a huge support to the resident and to the staff of memory care, but they're also a huge support to families. So it is really important when you recognize that end of life might be coming 3, 4, 5, 6 months. And you'll have providers that will help you determine that. But sometimes doctors aren't as astute as recognizing that and speaking that need to families. It's best to get hospice involved months earlier so that you can develop that relationship with the hospice staff, the social worker, the care staff, the home health providers, and the nurse, because those are going to be the people, the social worker and the nurse, that provide care to the family after someone passes. And I think that we don't get enough of that. We don't get enough of that support through the hospice benefit for our families when we get hospice involved too late. Getting off that soapbox, but a big believer in not being afraid of the word hospice. If you're working with the right hospice agencies, and I do hear very, very often that people have had negative experiences with hospice that might go back 5, 10, 15, 20 years. I want you to know that the people we partner with in the hospice settings do an amazing job. They do not push, they educate. So getting at least a referral to hospice and speaking with a hospice company so that you know what it's about in real time in this day and age can be really helpful to you as a family or someone living with dementia. Promise to get off that soapbox now, but really believe in the partnership that we have with hospice. Brain changes. These are the kind of things that happen in the brain that we don't really think about, but it is an illness of the brain. So I wanted to at least mention, you can see here where the red and the yellow are the frontal and the temporal lobe, and that's the lobes that are affected with frontal temporal lobe dementia. But the brain is made up of billions of nerve cells. Alzheimer's leads to nerve cell death in the brain. That's the simplistic version. The brain shrinks and our ventricles fill with fluid. Plaques, otherwise known as sticky protein formations, and tangles form. These are believed to be the culprits for the massive tissue loss and brain changes. So if you hear about tangles and plaques, that is what's happening in the brain. Nerve cell death, anatomical brain changes, and chemical changes in the brain are what cause the symptoms that we see in those suffering with dementia or living with dementia. I like to say living, I should not say suffering. Important benefits of early recognition is access to treatment. Alzheimer's disease relies largely, heavily on documenting mental decline, at which point we talked about Alzheimer's has already caused severe brain damage. Once we see the damage, once we see the changes in behavior, researchers are hoping and working on discovering a more easy and accurate way to detect Alzheimer's before these devastating symptoms begin. Access to treatment options. While current medications do not prevent, stop, or reverse Alzheimer's, they can help lessen symptoms such as memory loss and confusion for a limited time. And what I've seen in my nursing career is that the medications out there like Aricept, Namenda, Exelon, the earlier you get that treatment, the better off you're going to be. If we don't start treating with those medications in the early stages, it's almost too late at the late, early, and the mid stages of dementia. So it's really, really beneficial, and that's where we see. And in our setting, we don't often see people in the memory care setting until late, middle stages and late stages of dementia. So we're not able to advise people on that. You're really in the home setting still when the benefit of those medications can help you. Prioritizing health, optimizing your health, lifestyle changes, controlling blood pressure, stopping smoking. Can I say that enough? Stopping smoking is so important to your cardiovascular health. Participating more in exercise, and it can be as simple as increase your walking. Staying mentally and socially active can help preserve cognitive function as well. So we saw that in the early stages, people are tending to maybe withdraw a little bit from work and social gatherings. So this is the time when you really want to encourage. And again, we talk about destigmatizing. Find friends that allow you to be yourself. Even with those changes occurring, it's important to stay socially involved. Clinical trials, the Alzheimer's Association and the government, there are so many clinical trials going on right now. I think that in my lifetime, we will see either a medication that is much more effective in reducing the side effects of Alzheimer's, or a medication that could potentially cure. If we don't see it in my lifetime, we'll certainly see it in my children's lifetime. So clinical trials, an early diagnosis makes you much more eligible for a wider variety of those clinical trials, which help advance research and may provide medical benefits for the individual and certainly medical benefits further down the road for others. Providers can offer resources to decrease the risk of social isolation, and we'll cover a little bit more of the resources available in a later slide. Early diagnosis allows you to be open, and we talked about this earlier, but I'm going to say it again, to be open with your family and your support network about what you want during each stage of the disease. So recognizing and talking about Alzheimer's or memory loss, cognitive loss early on gives you more control. The person suffering with or living with the disease gives you more control over your life moving forward. It can give you peace of mind, reduce the burden on family members, and prevent disagreements between siblings. And we see that a lot. We see that one child will want a loved one living with dementia, will want that loved one to do all of the medical interventions as long as possible. And another child will say, we want quality of life over quantity of life. So if the person who's living with dementia is able to be involved in those conversations, it really prevents discord between families in the later stages of dementia. And those of us who work in the healthcare setting with memory loss, people living with memory loss, we see it all the time. And it's really an opportunity to reduce the stress on your loved ones moving forward. Planning ahead allows you to express your wishes about legal, financial, and end-of-life decisions. You and your family will be able to review and update legal documents, discuss finances and property, and identify your care preferences. Again, your care preferences can be identified in that durable power of attorney for healthcare and in your MOST form, your medical options for life-sustaining treatment. And the MOST form, I think some states probably went to the MOST or the POST form. Oregon and Washington State were probably two of the first states to do that, and I'm really excited that Colorado has that MOST form. That means we're having those end-of-life discussions at the state legislature level, which is important. You can also address potential safety issues such as driving and wandering ahead of time, which I also mentioned earlier on. Personally, my mother stopped driving when she recognized that she had neurological issues that weren't cognitive, but neurological issues that affected her reaction time. So it's really a tough decision to make because you give up a lot of independence, but is one of those decisions that's important to the overall safety for yourself and the overall safety for others on the road. So really important to talk about driving and wandering. We do see very often that when wandering occurs outside the home, that's when families start to think about or access memory care communities or adult daycare. So that's really important to have those conversations ahead of time, because safety is number one, especially during really hot weather and really cold weather. If you live near busy roads, having a loved one cross a busy street with cars is a frightening concept. Life with dementia, living with dementia. When you're caring for a loved one with Alzheimer's, it can be a struggle to identify activities that are within your loved one's capabilities and provide appropriate cognitive stimulation without adding stress. In a memory care community, these are a few things we do to ensure residents are engaged and stimulated cognitively. While many of these things refer to activities that can be planned in assisted living and memory care communities, they're also easy for caregivers to incorporate in the home setting. One thing that therapists have taught me over the years, and I've learned this from physical therapists and occupational therapists, muscle memories. So muscle memories are your long-term memories, which are the last to be affected. So muscle memories are dressing, taking the garbage out, like just long-term things that you've been doing for a long time. So those muscle memories help those living with dementia to continue to function effectively in familiar settings and familiar surroundings for quite some time. Families are often surprised at the level of skills that people retain as the disease progresses if they are performing tasks that are very familiar to them. This is because the long-term memory tends to be affected at a later stage than short-term memory. For example, taking trash cans to the curb each week, running a vacuum, doing dishes or loading the dishwasher. Those are all examples of that daily, weekly routine with muscle memory that people retain longer than you would expect them to. When you do decide to move into a community, it's really a great idea, and we do assist our families with this, is recreating the old home in the new home. So when a move to memory care is necessary, try to create spaces and views within the new home that are very similar or match the prior home. Take photos of dresser tops, counters, picture arrangements, and china cabinets so you can recreate surfaces and entire walls in the new setting. Arrange furniture. This is really important. When we see someone move in who's falling a lot or is stumbling over things in their apartment, it's often because we didn't arrange furniture in a similar way to their bedroom or their main rooms in the home. So when someone's getting out of bed, are they getting out of bed on the same side? That they normally get out of bed during the night to head to the bathroom? Making sure they're going around corners in the same direction they would at home. Orient the living space so the door, the exit, is in the same direction from the couch as it was at home. By doing this, we can enhance a resident's ability to continue to function successfully in their new setting. In a memory care community, it's so important to be mindful of each individual's unique needs. No one fits into the same hole, like square peg, round hole. No one is the same. Every individual is very unique. And that is what we as the trained professionals, we're trained to get that information from you. So asking the family by helping us complete a life story, which really takes us back to a lot of long-term memories. And some children may struggle to get that information to us from what was mom or dad's childhood like in their young adult years. So start talking about that now, because we're going to ask you about it when you come to a memory care setting, because we want to know, because as the memories become further and further back and the memories are more long-term, we want to know as a young adult what was impactful to that person. And that helps us in customizing a resident's plan of care. And we always go back to tweaking and revising that resident's plan of care as their disease progresses. So it's not a one and done conversation with families. It's, oh, we're seeing this new behavior, and let's go back to the family and find out, could this be something that is triggered by a long-term memory? And the family is key in helping us dig deep in changes in residents' behavior and cognition. There's many opportunities for activities that are right in front of us every day, and we don't think of them as activities because they're activities that we normally do throughout the day. But a caregiver, a family member, or a caregiver in a community, making the bed, that's again muscle memory. So doing that with someone provides you an opportunity to engage. Mealtime, setting the table with glasses or silverware, watering the plants, tidying up the room. Each of those things, though small and simple, can provide rich opportunities for engaging a resident or a loved one who is perhaps not interested in anything else you want them to do. Or other group activities. It's really important to consider those one-on-one activities. Families and professional caregivers should be alert to signs that a particular activity is causing frustration or anxiety. If your loved one is no longer enjoying an activity, it's time to make changes and try something different. Know your loved one's daily rhythms. We talk a lot about the daily rhythm of a memory care unit, and we also talk about the daily rhythm of each individual in the unit or in the neighborhood. Is there a time of day when he or she is more prone to anxiety or agitation? Are noise and distractions causing sensory overload? Some residents never do participate in group settings. It might be too overwhelming for them in the stage that they're in, or it could be something that was just unique to their personality. And we have to recognize that and provide that one-on-one attention during the day if they aren't going to be in group activities. And that's something that we're trained to recognize early on. Planning for more quiet time for those that are disturbed by sensory overload. can be really helpful in the day's rhythm for that kind of person suffering or living with dementia. Demystifying, destigmatizing dementia. A few from the World Health Organization, a few facts from them. Awareness and advocacy. Doing this Senior Expo, that's what we're doing. We're advocating, we're getting awareness out there. It's very necessary across all levels of society to decrease the stigma and the discrimination and to improve the quality of life for people with dementia and their caregivers. Dementia, with 50 million people potentially in the next 30 years going to be living with dementia, it's a public health priority. It's the 6th leading cause of death. So educating ourselves as healthcare providers and educating ourselves as we get older in our lives about what dementia entails, promoting a dementia-friendly society, improving attitudes to and understanding of dementia, it's key in reducing stigma. And being involved and being aware of increased research on dementia and promotion of innovative approaches and technology. And adopting technology, whether it be software or hardware, there's all kinds of new technologies being developed every year. And it's pretty overwhelming and pretty inspiring to see the types of technology that are coming out to help with dementia. Resources and engagement. I could talk about this for a full hour, but I'm going to tell you about a few resources and what we utilize at Balfour Senior Living for engagement. We are really strongly involved with the Alzheimer's Association. We do the walk every September, October. I'm really excited to do the longest day. We didn't get to do a whole lot with the longest day, which is the summer solstice in June. We didn't get to do a lot with that this year, but doing both of those events and having those be fundraisers. The Alzheimer's Association is the largest organization out there that's really participating in getting the research done. So really important that we support that. Another, Memories in the Making, which talks about art. Art and music and being creative are something that our residents living with dementia don't lose. So last year, my first full year with Balfour, I was really honored to be a part of the Memories in the Making. So throughout the year, those that are living with early stages, mild cognitive impairment, or early moderate stages of dementia, they go through classes, and it's very active in Colorado. And then we hosted, after all these classes, where they produce their artwork with an actual artist alongside them. So the residents living either at home or in a community, they produced artwork, and then an actual artist produced artwork alongside them. And then we hosted a luncheon and an expo at our Balfour Riverfront Park location. And we've apparently been doing that. I think this year will be the 6th year. I'm not sure how that's going to look for us this year with the pandemic, but it was really pretty awe-inspiring to see the art from the artists that were welcomed at the community in downtown Denver. Meaningful moments. Kate DeMiros, Associate Professor of Gerontology at Miami University in Ohio, calls these meaningful moments flashes of joy and purpose, however fleeting or small. Art, she says, can bring people together, make bridges. It's not about the past or the performance. It's not about what you can't do, but what you can do. And I really, besides art, music's another one, but I took artwork home. There was an auction, Memories in the Making did an auction, and they do this auction every year. The auction was, I think, in September of last year, and I took some artwork home, which is proudly displayed on my walls in my kitchen. Teep of Snow. Oh, let me talk about Balfour. We have some great resources here at Balfour too. Kathy Miracle, who I mentioned earlier, is our executive director at Cherrywood Village here in Louisville. And our expert in memory care services in Longmont is Mary Scallon, who is our Director of Health and Wellness, and Balfour Longmont will be opening later this year. So Mary is right in the middle right now of hiring and training her staff to be the best memory care provider in the Longmont area. So we're really excited to have Mary on our team up there. Teepa Snow. Anyone who knows anything about dementia knows about this internationally known Teepa Snow. She's an occupational therapist by trade. Her website is called Positive Approach to Care. And for the last 20 plus years, she has just been extremely passionate about memory care. We are blessed to have 3 or 4 people at our company. I think it's 4. We have 4 people, 2 at our one downtown, 1 at Stapleton, and 1 at Littleton, so that are actually the trainers for the Teepa Snow Positive Approach to Care. Her GEMS model, which is based on the Allen Cognitive Scale, with each type of dementia, the gems are the color of gems, and it starts with sapphire and goes all the way to diamond and pearl. And the GEMS model, if you haven't had a chance to hear about the GEMS model, I advise you going to the Positive Approach to Care website and read a little bit about it, because it really does each gem. She matches up strengths and challenges to each gem at each stage, and it is really it's really wonderful to see. And I know that even if we don't teach that Teepa Snow GEMS model, a lot of the staff who work in our memory care neighborhoods, we do talk about the GEMS model quite a bit. Understanding strengths and abilities that remain during each step of the dementia journey can have a huge impact on quality of life, and Teepa Snow has definitely done that and continues to do that. Music and memory. I was introduced to musicandmemory.org several years ago. There's actually on YouTube a great documentary that's about an hour long. Whether you're part of the musicandmemory.org movement or program, that involves downloading music that's particularly special to each resident individually onto an iPod and having headsets. You could see the picture on this slide of a woman enjoying music, and you can see her eyes are closed and there's total joy on her face. She's listening to something that evokes memories for her that are pleasant memories. And most of the time, music evokes pleasant memories because that's something we do to relax, to unwind. Music from their specific era. Part of the music and memory program is to sit down with the family members and to ask, what kind of music did your loved one listen to back in the 40s, 50s, 60s, and 70s, and design a playlist around that. So if you're interested, look up the music and memory video. It's about an hour long on YouTube. It's really a great program. And a lot of us, we do use. We had last year in the summer, we had a car show at our Stapleton location, and we had a DJ that was playing music from the 60s and 70s. And we had residents just come alive. Residents from our memory care neighborhood were outside really enjoying the music and just loving that music from the 60s. Another thing I'm really passionate about is gardening. At Balfour, we use our Eldergrow gardens, eldergrow.org. And I do have a little video that I'd like to show you, and I'll show you as soon as I finish this slide. But Eldergrow gardens allow residents to enjoy gardening year-round. They are garden carts that are inside our communities. They improve motor skills, they improve sleep, they reduce falls, they reduce agitation, they improve self-esteem, and they can act as an antidepressant and elevate mood. Staff use the garden cart as an intervention, such as redirection during periods of agitation or distress. The scent of lavender on their fingers or basil can completely alter a stressful moment and help the care staff reduce, bring that mood down to a mood that's a little bit different. Eldergrow also includes programming that helps our care staff and the culinary team use herbs and vegetables from the garden for snacks and meals, which we really love. And then another software that we initiated, I would say about a year and a half a year and a half ago that's now in all of our communities is LifeLoop, and it's truly an engagement software. It really was designed around programming and engagement and getting the family involvement. They also have enhanced services like making your appointments for transportation, and they also have maintenance and housekeeping requests built into the platform. And that helped us reduce duplicative services. So we had some duplicative services using another housekeeping maintenance software, and we were able to stop using that and use all the facets of LifeLoop, which was really helpful operationally for us. We've used LifeLoop to engage with residents and their families even more so during the pandemic, and conducting, our executive directors have done virtual town halls and resident council meetings. And for those that can't attend live, we record it and we put it on LifeLoop so our residents and families can watch it later. Our executive directors have invited guest speakers. They've invited either members of the executive team or outside speakers to come and talk, but it really enhanced the communication during this very challenging year that we've all been living through. We also do remote programs. So, while residents have been in their apartments, we're either doing hallway, like where people are at their door, or we're doing resident programs through LifeLoop. So we can do our exercise program, but we're doing it through LifeLoop. And they can join from their smart TVs in their rooms. And another thing is when we tag residents in photos that we take, whether it's a photo, in the past it was photos in a group setting. We are able now finally to do group settings again in small groups. But we did one-on-one photos of staff with residents, and having families be able to see that really reduced some of the anxiety and frustration for families who aren't able to visit as much anymore. I'm going to show you a real brief 2-minute video about what Eldergrow is about. Another software or product that we are using or planning on using is Eversound, which is an amplifier technology with headsets and an amplifier. And we just had a presentation yesterday from the co-founder of that company for our life enrichment teams, and we're budgeting that for next year because hearing loss is very isolative. So those residents that are suffering with hearing loss, we may not even know how much they can engage in our programming because they can't hear us. So Eversound technology is one of those technologies. It's been around about 5 years, and they are in 800 communities nationwide right now. But being able to hear, and very often people with living with dementia don't want to wear their hearing aids anymore, but we can get them to wear a headphone for 10 or 15 minutes to participate in a program. Very important for them to be able to hear music and for them to hear their caregivers that are talking with them during care. So we're going to go ahead and watch this video.
Pick a card, any card. Okay, nice selection, madam. And I'll scramble this up for you. Oh, pick a card, any card.
Oh, I like this one.
Okay, wonderful. So I'm hoping, we'll start with Carol.
Now that's pretty.
I'm hoping that Carol, you can identify this plant, which is a cordyline, in the garden here. Do you see a plant that matches the image you see here?
Yes, I do see.
One, if you look.
Is it this right there?
It is! You got it! So we've got the brown version of the cordyline.
Oh, yeah.
What's cool about this one, in Hawaii, it's native to like the tropics, and in Hawaii, they would actually use these and dry them to make the hula skirts.
Oh, nice.
Yeah.
I didn't know that.
How cool is that,
That's
right?
cute.
Try it out. Here, let me give you one. Give you one of these. Here.
Thank you.
Go ahead and rub your finger. There you go. Kind of rub it. Get those oils coming out.
Oh, I love it.
Oh, good. I was hoping to ask Jackie to look for a plant that fits this description. Are you ready? Are you ready for the challenge?
Well, I can try.
Okay, I love it. Okay, that's all we can do, right? Okay. So, you're looking for a plant that has grayish green leaves, grayish green, so a mixture of gray and green, and then the texture of the leaf is bumpy. So let's try some of the leaves of the different plants around you.
Oh, I love
Would you
babies.
describe that leaf as bumpy and fuzzy?
Sort of, yes.
Okay, is that a grayish green color though?
No, it's a green color.
Okay, it's just green. Can you see a grayish and green color?
It's green.
Okay, just straight green.
I think so.
Thank you, everybody, for watching that brief video. It's not letting me go to my next slide. That is the actual end of the presentation. Let me go here. Let me go. There's my reference page, and then questions. Ready for questions from the group.
Well, Jeanette, as usual, your presentations are so incredibly thorough and so interesting. You know, yesterday we heard in a presentation by Dr. Holloman a very interesting statistic that perhaps you could spend a minute talking about from your perspective, that people today are more worried about, when they do surveys, more worried about brain issues and dementia and Alzheimer's than they are about any other fatal disease, whether it be long-term heart disease, cancers, strokes, things like that. So perhaps you could talk about that and how that might have changed.
I think that there's a really healthy fear of losing one's identity and not being able to recognize who you are as a person anymore. There's also that fear of not recognizing your loved ones and losing that ability. So it's a very real fear to face. And there's so much more science out there now where there's markers that they can identify that you're at a higher risk for Alzheimer's. So there's more awareness, I think, of the science out there and the ability to, in families, what I've seen as a nurse these last many years is that families, they suffer 2 deaths when they love someone who's living with dementia. They lost their mom when the diagnosis happened and they got to those late stages, and then there's the final death when someone does die. So it is very traumatic. There's blessings with dementia, but there's a lot more sadness and trauma and loss that goes on. So we are, in our memory care world, we just try to support families through all of that. As hard as it is, I've had family members ask me, how do you do this? How do you do this for a living? I wouldn't want to do anything else. I feel like it's my mission, it's my calling, as do many of my peers, not even just Balfour peers, but I meet people all the time at events, and it truly is a calling to care for people at their most vulnerable when they can't speak up for themselves. So it's really a lot of fear out there, Al.
Well, it's obvious that you have a great care, that you care so much and you have great passion for it. Perhaps you could spend a minute talking about the differences in facility housing at the various levels of dementia for families who are thinking about this and are facing it versus the ones that are trying to do it alone at home.
Yeah, I think that families do a tremendous job of doing their very best to keep people at home as long as they can, and I commend them for that. What we see is that we see a lot of caregivers when they come to us who are extremely exhausted. Their own health is suffering. So we try to be that support and encourage people at least to start with adult daycare. So that's one level where they can, it's been a little more challenging during COVID though, Al, because the state hasn't allowed us to operate our adult daycare because we're bringing in people from the community and it increases the risk of bringing COVID-19 into the building. But overall, we were doing a pretty healthy daycare program at Cherrywood Village here in Louisville. And so we miss that ability to connect, and it's put caregivers in the home setting at a true disadvantage, this year has. So we have seen more need-driven referrals coming to us saying, I've had to do this all by myself now for 5 or 6 months. What can you do for me? And we have Our memory care units have a wide variety. We have people who are early to late early stages to early middle stages, and we have people that come to us already very late moderate stage. Very often the physical care needs in the late stages of dementia have already moved into our communities. If people can afford to bring in care into the home, it's not always easy to find reliable care, whereas if you have someone in a center or community like ours, we do all that staffing and that worrying about making sure we have enough staff to care for residents. So that is one burden taken off of you when you move into a memory care setting.
Perhaps you could spend a little bit of time talking about the financial impact that that housing would have on families. From what's covered, what's not covered, to a range of expenses on a monthly basis associated with memory care facilities.
We really like to keep it as simple as possible for our residents and their families. So there is a monthly rent. Unfortunately, private pay, memory care is private pay. So there's a variety in ranges of rent depending on location of communities. We do have some memory care communities are all inclusive where they don't have different levels of care. We do have 2 levels of care in our memory care because we really want to be able to keep someone in that assisted living memory care setting and not have to transition them to a higher level of care like skilled nursing. So as people age in place with later stages of dementia, there are more physical care needs and sometimes there are more behavioral care needs. So we do have 2 levels of care, and that ranges from anywhere from $400 to $600 extra in level 1 care, and then level 2 care is anywhere from $600 to $900 depending on the location of the community. A lot of care is included though, so we know that residents are going to have more care needs in the memory care setting. So there's a certain number of care needs that we meet as no additional charge on a monthly basis. So we do reassess every 6 months to see where people are at in their care needs, and then with a change in condition as well.
And just one question out of curiosity, the growth of Alzheimer's and dementia-related illnesses, and the rising death level of related diseases. Yes, it's clear, as you stated, that it's caused by aging, but is there any research that's showing any other promise as to why we're seeing such a dramatic increase, or were we not recognizing it before?
I think we're doing a better job of identifying, but they are finding in research that there is a familial link. So there is a genetic link. There's still research to be done. And to be honest, Al, I didn't dig in as much as I would have liked to into the proteins and the different biomarkers. I didn't want to bore the audience with too much detailed science, but I was scratching the surface and I want to go back because there's a lot of detailed science out there about biomarkers. So I think we're just doing a much better job. There's more neuropsychiatry, more neurologists that are better trained in this. So anybody that was misdiagnosed in the past with frontal temporal lobe dementia, misdiagnosed as a mental illness, is now being properly diagnosed with frontal temporal lobe, which is
Actually,
very helpful.
we had a very good session yesterday with an audiologist, doctor of audiology, who talked about how hearing loss is tied to the beginnings of dementia. So yes, there's definitely all kinds of different links. That's very interesting. One question that came from the audience is the Longmont facility up and running in all areas yet?
It is not, but they're open for tours, scheduled tours. We are very close. We are looking to possibly have our temporary certificate of occupancy where the staff can move in late November. And we're hoping to get the state out there to do our licensure survey. So we're hoping to have residents in early to mid-December. So we're getting close.
Wonderful, wonderful. We're very happy, and thank you again. We're right at the end of our 1 hour, so I just want to thank you from all of the participants for your incredible presentation. As usual, it just provides so much information on such a vital piece of our lives, and apparently continues to be a growing piece of everybody's lives as we live longer. So I thank you from all of our participants and myself, and we look forward to more sessions with you in the future.
Thank you so much. I'd be
Thank
happy
you.
to
Say
join.
hello to Louise for me.
I will. Thank you. She's here with me. Thanks,
Hi,
Al.
Louise. Take care. Thank you so much.
Bye-bye.
Bye-bye.